Thank you, everyone, for joining us, the Private Practice Study Group, for our next webinar. I'm Mark Dubin. I'm the chair of the Private Practice Study Group. Before I hand it off to the webinar's organizers, I wanted to personally thank Dr. Yaremchuk, president of the Academy, for support of the organization, Dr. Deneni for his unwavering support, and the entire board. I also want to give a special shout out to the staff who are going above and beyond their assigned duties to help us out, as we're still a section. Elise Swinehart, Tina Maggio by name. And with that, I'm going to hand it over to Dr. Siebert and Dr. Gold, who are PPSG executive members who've been organizing this, and I'll let them take it from there. Thanks, guys.
Thank you guys for being with us tonight. We have an awesome panel, and I hope you have lots of great questions tonight. And moderating our panel, I'll go through and do introductions of each of our panelists. And our moderator tonight is Dr. Angela Powell, and I will give you a brief introduction about Dr. Powell. Do you want to advance that slide? Dr. Powell entered active duty service for the U.S. Navy in 2006 upon completion of her residency at University of Pittsburgh Medical Center. She was then stationed at the Naval Medical Center in San Diego and quickly distinguished herself by ranking among the top 10% of military otolaryngologists. She was then selected to be the spokesperson for the Navy Medical Leads Assistance Program, aiding in recruitment and retention of minority healthcare providers. She then was deployed on a humanitarian mission in 2007, where she provided ENT care to a dozen Central and South American countries, and then returned to San Diego, where she received award after award, including the Resident Teacher of the Year Award. And then she received the Program Director's Award for outstanding contributions to the residency program. Through her time in the military, she once again received multiple awards, including Navy and Marine Corps Achievement Medals for distinguishing herself as an exceptional clinician, Military Health System Female Physician Leader of the Year Award. She received a Navy and Marine Corps Commendation Medal just prior to her transfer to Walter Reed Medical Center. She completed her tour and then transitioned to the reserves in December of 2019 and received a Joint Service Commendation Medal as a testament to her exemplary service throughout her active military career. Then she completed her tenure as chair of the Otolaryngology section of the National Medical Association and president of the Harry Barnes Medical Society in July of 2022. And she served as the first African-American to chair the Women in Otolaryngology section of the American Academy from 2019 to 2020. She transitioned from active duty to a civilian practice in December of 2019 and enjoyed 2 years as an employed otolaryngologist for the Guthrie Medical Group, before embarking on her own solo private practice venture as the founder and owner of Plattsburgh ENT, which opened its doors in October of 2022. Our academic physician tonight is Dr. Krishna Patel. Dr. Patel is a full professor and director of facial plastic and reconstructive surgery in the Department of Otolaryngology Head and Neck Surgery at the Medical University of South Carolina in Charleston. She is also the director of the Craniofacial Anomalies and Cleft Palate Center at MUSC. She serves on the executive board of directors for the American Board of Otolaryngology Head and Neck Surgery and has since 2020. Our employed physician tonight is Dr. Andrew Coughlin. He is a fellowship-trained head and neck surgical oncologist in Omaha, Nebraska. After holding a hybrid position between the academic university and the private hospital for 4 years following his fellowship, his team has pivoted to an entirely hospital-employed model with the private hospital. They continue to have an academic affiliation with Creighton University, allowing them to continue fellowship education as well as resident and medical student education. He practices the full spectrum of head and neck surgery, including ablation, reconstruction, and skull-base surgery. One of our private practice physicians is Dr. Neil Burkhalter. He is a private practice otolaryngologist in Columbia, South Carolina, where he has been for the last 10 years. He recently left hospital employment to join private practice, a venture that he has found educational, challenging, and rewarding. He is also very active in medical student education and has led multiple medical mission trips to South America. He practices general ENT, but especially enjoys pediatrics, rhinology, and endocrine surgery. And when he's not working, he's usually juggling something pink or glittered with his 5 daughters. And our other private practice physician is Dr. Greg Davis. He is a rhinologist in private practice in a suburb of Seattle. He is a clinical associate professor at the University of Washington, where he previously practiced academic rhinology as the director of the Rhinology and Endoscopic Skull-Base Division and Fellowship. He serves on the board of directors for the American Rhinologic Society and continues to be involved in several clinical trials. So as you can see, we have a quite accomplished panel and quite accomplished moderator. So I think we can get started.
So if everybody, we're going to pass it over to our moderator, Dr. Powell, who will begin our panel.
Well, thank you everyone for participating in this panel, and we're hoping that you will find your happy place through our discussion today. We have several questions that have already been submitted for tonight's symposium for our panel, but please feel free to enter questions into the chat box, and you'll either see the responses from our panelists within the box, or we will present the question to the group just based on kind of the direction that the discussion leads. And we probably will have more questions than we have time to answer. And so if your question wasn't answered, there will be at the end of the discussion today a way for you to communicate with the private practice study group directly so that we can continue to answer your questions and be present for further discussion. I'm going to share my screen again here. Oh, and I just wanted to say that I was a nominee, but I didn't actually win that Military Health System Female Physician Leader of the Year award. So I wish I did, but but thank you for giving it to me anyway. So here I go.
You deserved it.
And just confirm that you're able to see the screen there. So we have questions up. The first grouping of questions relate to trainee career decisions and transitions. And I'm not gonna to direct any of the questions to any one panelist, so feel free to just jump in. Our first question related to the pros and cons of choosing careers in academic or private practice as a new grad.
Well, I'll kick it off. That's a big question that every resident struggles with, or sometimes struggles with. So, short background, I started academics, was in academics for 12 years until jumping into private practice 3 years ago. And I chose academics because I still had an interest in research and teaching. And if that's the case, then that's kind of the direction that you go. It's vastly easier to be an academic first and then go to private practice as opposed to jumping the other way from private practice into academics. And the benefit of being in academics is you really solidify your position in the community as an expert. It helps hone your skills. You see the hardest cases often, and then when you transition to private practice, if that's what you choose to do, you've already built a reputation that you're a go-to person. So that's one of the benefits, at least for subspecialists. And again, it just comes down to, in my opinion, if research is what you want to do, start off in academics. If it's teaching, go academics, but there's so many of those opportunities in private practice. I'm in private practice. I still teach residents from the military medical hospital just down the street. I'm still doing clinical trials. So there's a little bit of both, but I don't think I could have had those opportunities if I had not started in academics.
Greg, I definitely agree with you on that. I think it's definitely easier to go from academics to private practice. I was in academics, kind of this hybrid model for, 4 or 5 years, and then transitioned over to being hospital employed at the other hospital that we were already working at. And like you said, we continue to train residents. We continue to work with medical students. You can continue to do clinical-based research and stuff like that. I think that one of the other benefits to academic medicine, though, is that if you really have a key niche based on your fellowship training or something that you were really, excited about during residency and you wanted to go further into that and be the specialist in that. I think there's significant value in, the academic side of things, and potentially also mentorship. I think sometimes we forget about all the mentorship that can happen there. But with private practice, I mean, if you join the right group and you have the right people around you, the mentorship can be very, very good there as well. So I think you have to, consider all of your options when you're deciding whether you're going to academics or private. But I think either are very good.
Yeah. I think that I totally agree with both of you. And I would say I've had a pure academic career, and definitely one of the draws for me was that I love teaching. I love being in that environment. I can tell you now that I'm in this world, that is definitely what keeps me here too, is that I really love it. I now have a fellow, so it's incredibly subspecialized. And I can, like, in single cases, just like really nerd out with this person who loves it just as much as me. And there's a lot of fun in that. And it's an enjoyable way to practice. The other thing I really love about academics that I think is a huge pro, which I think is now changing a little bit. I think when I first started, private practices were smaller. So when you went into private practice, I think it could be very isolating sometimes. Whereas in academic medicine, I have all these subspecialists that if I feel like I need some help, I felt like it's very easy for me to just go next door and find my rhinologist or my head and neck partner. But I know that now private practices have gotten much bigger, and that's probably changed a lot of the environment of when you're like in private practices. Obviously, I don't know because I'm not in that setting, but certainly that to me is a pro of academics, is that I have a lot of like fabulous people that I feel like if I feel like I need help, I can very easily go to them. But I've also gotten very niched out. So I feel like I've also lost a lot of my knowledge and don't feel comfortable practicing into those other areas.
So now what about fellowship trained graduates that are interested in general ENT jobs with a focus area? Who would like to dive in on that topic? Well, I guess I'll speak to it while everyone else is thinking about it. Considering that I was in kind of the academic environment in the military for a period of time, and then also in smaller facilities where we were all generalists working in kind of the equivalent of a level 2 trauma center environment. I think that having that fellowship training and then working as a generalist, if you're in a smaller practice setting, sometimes is very helpful, because there's a challenge for the patients to travel from, say, a small rural community like where I'm working to see the specialists that are outside. So if you have that kind of specialty niche area and there's enough of a population of patients with the pathology that you're interested in treating, it would benefit you to join a private practice. And I think that you would also see enough pathology that it would keep you from experiencing skill set attrition. But I don't think that's the case in all instances. And so it would be worthwhile to research the practice environment and the patient mix and the number of other tertiary referral centers in the area to ensure that you're not going to see one or two of that particular, interest area in your patient referral base in a monthly basis or, throughout the year, because then it really wouldn't be worthwhile for you.
Those are great points, Angela. The other reality is that this is the typical scenario. People are going to go into fellowship and look for a community practice job. And you need to have the expectation that you're going to practice general ENT with your subspecialty as well, but it's not going to be all subspecialty. And it's pretty frequent that past fellows or other rhinology fellows will call me and say, boy, my fellowship was so amazing. I had all these just intense, crazy cases every day in the OR, and now I'm in practice and it's more kind of run of the mill. And that's what life is. So you should have the expectation that you're going to start off doing part-time general ENT, and hopefully you like that. But as your practice grows and you get your reputation out in the community, that will hone it down to your subspecialty if that's what you want.
I
The
agree
next
with that, Greg.
question-
Sorry.
No, go ahead, Melanie. Sorry.
I was going to say the
You're
same
fine.
thing. I did a fellowship, and when I got out of my fellowship and went into practice, a good portion of my practice was endocrine surgery. But as I was in this setting, I realized, gosh, I liked meeting these moms with kids with ear infections, and I like connecting with these people with tongue-based cancer. So while I did have, and still to this day, a good portion of my practice is endocrine, it's kind of fun to do general, the other aspects of ENT as well. So I think in a lot of practices, you do have the ability to, concentrate on your fellowship training, a decent amount. But I think it's good to have this skill set of doing general ENT as well.
So this next question on the trainee career decisions has to do with salary. And you'll see a little bit farther along in the slides, there's a whole business of medicine section that will be talking a lot more about compensation models and negotiation and renegotiation of contracts and that kind of thing. But let's just kind of start with the typical salary for new grads and what the different models are. Can someone speak to those options?
Yeah, I mean, I can start. So I will say that most of the time you're probably coming in on some type of a guarantee for a couple of years, or you're not necessarily partner. You're starting off early, and even if you're in academics or whatever, there's probably this early payment that you're getting while you're trying to build your practice. And at some point, there's probably the ability to get bonused based on productivity, or there's always a metric. And so for me, when I started out, it was, this is your base salary, but if the group does well beyond that, then you have the potential to get bonused based on the group's overall performance, and your extra performance beyond what you've done went into that. So for me, that's how it always was. And for me, being kind of the academic and hybrid with a community hospital, our negotiations have always been between the group not between group members. There's not really a founding member or anything like that. It's really with the administration and coming to a common decision on that. So ours is a little bit different, but it's kind of fun in some instances to negotiate with the administrators of a bigger hospital. Sometimes it's quite frustrating, but that's how it was for me.
I can speak to the academic. I think when I got hired in, that was a while ago, but I just recently hired a new partner. It was very similar setup where similarly, there's about a 2-year guaranteed salary. When I think there's a misconception that, and I think there are still some institutions like Mayo where you have like a set salary and they get paid nicely. So it like keeps everybody happy. But I think most academics today are not like that. And that's true where I practice. It is almost what you produce is kind of what you get paid. So it's more similar to private practice than I think people realize. And so, but it's and we used to be collections based. And then about 2 years ago, we went to what's called RVU based. And it really kind of equates very similarly, to be completely honest, other than it takes care of the fact that we take care of a lot of unfunded, non-insured patients, and you actually now today get credit for that. Whereas 2 years ago, that was free care I was delivering. And in academics, you're going to have to do that. And so it does, for me, I actually benefited. It worked out really well. But the RVU system may go away because I think hospitals are struggling with it. So it's not too. The one thing I would say though is I do think you hit a ceiling in academics. You're not going to ever make enormous salaries, at least best I can tell. And that's the other kind of limiting factor in academics.
I want to also comment about private practice, and there's, we think about private practice as a true private practice, like group owned practice versus hospital employed. And my group is small, although we have a larger umbrella of about 38 ENTs, but my group is 5 ENTs. And we went through a hiring event a year or so ago, and looking at what the hospitals will offer new grads is pretty impressive. I mean, they definitely will pay a higher amount than most private practices. But as Dr. Patel was saying, the ceiling is there and it's real as an employed hospital physician. If you're in a group practice, you have the opportunity to own your ancillary services, to own an ambulatory surgery center, and that can really significantly contribute to your take home, not just like your salary of what you're making, but it's, think about those facility fees that often go to a hospital. Well, if you own your ASC, it goes to the ASC owners. So that's for really something to think about. Don't just think about those first couple years when you get out of residency or fellowship and you see those big dollar figures from the hospital. Think about the long term, and you're probably going to be an employed surgeon for a couple years, and there's likely going to be a buy-in that's going to seem to hurt, but in the long run, typically you would make more in a group practice.
This last question from the trainee career decision topic is an interesting one, because I know from the private practitioner perspective, we're like wishing and hoping that we would have more people interested in applying for positions with us. And the individual who submitted this question wants to know what makes an attractive applicant and how to go about inquiring about the different job opportunities that are available.
I know in academic, I feel like sometimes that it's harder to get an academic job because it is a little bit for early on. I mean, obviously it gets posted, it goes through the whole pathway there, but early on, there's like word of mouth about people looking at for someone, a potential new partner. And so I think when you're a resident, you definitely need to like reach out to your attendings to kind of inquire about that. I get emails all the time, just people looking for potentially moving down for an academic job and they want to live in the Charleston area. And I would encourage people to do that because I always keep those emails for when then I started to look for a junior partner.
I think part of this, especially in private practice, the PPSG, this private practice study group, has become and will continue to grow as a place for private practice people looking for jobs. But I think continuing to kind of ask around, word of mouth still seems to be a great option. The ENT Connect or the Academy's search for job search, they have a whole website that's actually really well done. And so that seems to be a pretty good place as well. I think the second part of that question, what makes a good applicant? I think kind of understanding or realizing a practice and partners are looking for just that, a partner to come on. And for you to come on and show that, hey, I really want to be part of this for the long haul. I really want to see this grow. I want to grow with this group and grow together and add to the collective good of the group, rather than coming in and asking questions. What about me? What do I get out of this? How do I get this? How do I gain this? How do I get this, me personally? But it's a much more attractive candidate to come in and say, wow, you guys look like a great group. How can I contribute to the group? I mean, I'd like to know what's in it for me too. I want this to be a two-way street, but how can I contribute to the group? And what does this look like 10, 15, 20 years from now? How I can really contribute to the group and grow the group for the greater good of everybody in it. That's a much more attractive candidate, in my opinion.
So there's a question out of the Q&A I'm going to present to the group before we continue with slides. And they're saying, for those who are considering transitioning from academics to private practice, did you feel like you were letting go of the interesting cases, the complexity in your practice, or did you feel like you could still keep your practice stimulating on the private practice side?
I typed out a response, and what I said was, once you build your reputation, those cases are going to continue to be sent to you, especially if you stay in the same area. You build your referral base, and that's so important, both for academics and private practice, but probably more so in private practice, because providers have to choose to send you patients. And if you provide good, compassionate care, they're going to keep sending you the complex cases. Now, the question is really, do you want to keep seeing those complex cases if you're in private practice? If you're not in a hospital employed model, do you really want to go to the hospital every afternoon and around on those patients, or maybe do you want to give some of those up? The nice thing is you have the option to do that, but I've never, in 3 years in private practice, after 12 years of academics, I've never been bored in one of my OR days in private practice. So it's still a lot of fun.
Greg, I'd agree. I actually typed a response and actually quoted you from what you said earlier. So I agree. I think you build your reputation, you become the expert. And when you leave, you kind of expect those cases to continue to come your way. And I agree. I've never felt like I've been bored or anything afterwards.
I would say, if anything, if you've established a reputation and your name is out there, often the patients will find you. That's just something else to consider. It's not just the referring providers that you're getting word of mouth, that social media presence that you have, and the patients communicating about the quality of your care also gets the complexity through the door. For employed physicians in the group here, this is our next topic. How were you able, this question specifically was saying, how were you able to identify red flags if you took this position and then all of a sudden it was kind of going south? What types of things were kind of raising alarm bells for you? And then can you describe, or give some examples of what you've seen?
Yeah. So I think the nice thing for me that may be a little bit different than a lot of people who are coming into this to be, an employed general otolaryngologist is that we had already had a relationship with this hospital and the administration. And so, we didn't really have this idea of a negotiating a retention bonus after our first contract or anything like that. But there are red flags that make you question. So when we first made this transition over, we had been doing this RVU model for several years. And you got to remember that all of these places are big institutions, and there's always people that are counting your RVUs for you. They're counting, what consults you see, how many patients, this, that, and the other thing. And you got to remember that people can make math look the way that they want it to look. And so I continue to this day to be very vigilant on what I'm billing, how I'm billing it, how I'm dictating my OR notes and stuff like that. And every single year you go back and you find out that you're probably being undercompensated if you're in an RVU model. The alternative to that is to, just argue to go to strictly a collections-based model. And you can do that. And I've never been in one of those, so I don't know how that would look from an employed standpoint. But I think RVUs are still king in employed models. The key is asking them to do market analysis and find out where you should live in terms of, someone in the Midwest or the South or the Northeast, and what your average RVU should be. And if you go above and beyond that, make sure it's in the contract, how you're going to be compensated for it. Most of the time you're going to have on-call obligations. There's going to be things like that you're going to have to do, but make sure that all those things are spelled out in an employed contract.
Dr. Patel, I wanted you to respond. I know academics and employed are not identical, but I know they're also very similar. And so what have you seen for red flags in an academic institution? And, can you give an example of something that you should be looking out for in that context?
I mean, I think similarly, I'll be honest, when I came into my job, I was pretty naive about a lot of what goes into running a hospital. And it is interesting because it's not like we have these charts that say, okay, if you make X amount of RVUs, you're at the X percentile and that's the X salary. But that's actually not true, because there's a certain percent of dean's tax. There's a certain percent of overhead. There were years that I actually had to pay rent. And at one point in time, the hospital kind of change it. I mean, it's very much true. Like, you have to really take into account what they are calculating in to your RVUs or your collections. So it was a little bit confusing to know exactly how to know that I work this X amount and that would lead to this much pay. Like that was always a little bit of a challenge. And so I totally agree with Andrew. I think you really need to kind of very clearly state it and try to encourage transparency. And it can be very hard to get transparency in huge centers. And I some of it I really get, like I understand why they have to be that way, but I also think you have to stick up for yourself. You do have to really watch and monitor. And just because you're in academics does not mean that you can't follow that and monitor that. I constantly have to pay attention to that within my own practice.
In the interest of time, and believe it or not, we actually have about, 7 more slides worth of questions. The negotiating retention bonuses and comparing private equity and hospital employed positions, I'm going to put a pin in those, or if any of the panelists are willing to respond in the chat on those topics, that would be great. On-call responsibilities was a common thread for all of the different models. And so I'm going to go straight to that question, and anyone can jump in with that.
I'll start just because I think that is actually one of the perks of being in academics is that I have, and again, now that private practices are larger, maybe it's less of an issue, but I have 20 plus partners. So when we rotate through in the year, it ends up not being a lot of general ENT call that I have to take. And we do step in for each other when things get complex. Like I can look to my partners to come in for very challenging things that will come in even if it's in the middle of the night, which is really reassuring. And I have fellows also that can do that. So call is a plus for me for keeping this job.
Yeah, I think one of the things that you'll, if you're at more of a community-based hospital doing employed otolaryngology, is that a lot of oral surgeons have left many of the big hospitals. And so you may find yourself taking a lot of oral surgery call or dental call or things like that. And I think it's just important early on to say what you can and can't do. You know, I really do have a unique situation. We pretty much do the vast majority of our practice is all head and neck. And so we do some general ENT type stuff, but a lot of the general ENTs in the community kind of manage the general ENT things for us. And part of that is because some of my partners are general surgery trained and some of us are ENTs. And so, you know, that goes into the negotiating with the hospital. Like, listen, we're not going to do, you know, general ENT call because some of my partners are not trained to do general otolaryngology. So I think it just really comes down to what you negotiate with the hospital and the reason why you're going to negotiate it that way. And most people are very thoughtful about, you know, supporting you in the way that you want to do that, but you're going to have to take call to some extent.
Yeah, I want to bring up the private practice study section survey that Mark Dubin really was key in sending out, and a lot of other people, I'm sure. And Dr. Denani was instrumental in doing this. And I would encourage all the viewers to read through that survey results. It was helpful for me to see because certainly on call, it's a good thing we know that we're going to be on call going into medical school and residency, because if you didn't know and you got there and all of a sudden you're on call, it'd be pretty rough. Yeah, switching from academics to private practice, it is more challenging in private practice. We're on call a lot more frequently. Cases aren't nearly as challenging as they are in a tertiary center in academics, but it's a reality. And the challenge with otolaryngology is it's such a relatively small specialty compared to some of the other surgical specialties that we don't have some of the resources, most of us don't, that are available to the general surgeons and even orthopedic surgeons who have night float, who have APPs that take daytime call. You know, our hospital doesn't provide any of those, and none of the local hospitals do, but they do for general surgery and for orthopedics. So I'm hopeful that as time goes on and we become more focused in quality of life, that we will find ways to improve our call, the quality of life. I think several people who are near retirement are finding some additional revenue and enjoyment in being locums on call. And I think there's room for improvement, and I'm glad our academy is taking a look at that.
Can I just ask, within the private practice world, do you get paid for taking call back for hospitals? I know in academics, I do not. I was just curious if that's how that works?
Yes, we do get paid. And I did not get paid in academics, but we do get paid a little bit. Now, if you have to cancel a half-day clinic or an OR case to go take care of an emergency in the hospital, then it quickly gets negated. Fortunately, that's pretty uncommon. But yes, most and the survey results, I can't remember, Dr. Denetti or Mark, maybe you guys remember what the result was, but I believe the majority of ENTs in private practice were getting compensated for being on call.
Yeah, I agree. I'm pretty confident that was what the survey outcome said, that most.
Yeah, 2/3 were getting 2/3 were getting compensated for call at this point, and that's in the bulletin from November, actually October 31st. It was published. If you want to go back to the archives, it's in there. The results from that survey.
So for networking, I think this question came in and was directed more for academics, but I think that it's referable to any of the practice paradigms. And so what recommendations do our panel members have for the cross-specialty networking to boost referrals, especially if you're new to the area or new to the department?
I think a personal text or phone call to the physician who sent you a patient is really unmatched. And I spend a fair amount of my day texting referring physicians or calling if it's a complex, or so having a being easily accessible to them. So text is an easy way to do that. And so giving them a quick, easy live feedback of, hey, I just saw your patient. Thanks for sending them over. Here's what the plan is. And so having that really quick, easy exchange with a referring physician is quote networking, but it's a really easy, simple way to do that. And it makes you more accessible to them in the future. And I think it kind of feels like they're kind of in with you and solidifies them as a referring physician. So that's been really helpful for me.
Yeah, that's super key. You just have to be available. Always say yes. If someone calls you and asks you to get someone in, the answer should be yes. And you might have to stay late or skip lunch, but being available is pretty important. Also think that every patient is an advertisement for you. That can be good or bad. So hopefully you're nice and compassionate and deliver good care, and those patients are going to tell other people and their referring docs. Also, always send the referring docs a note every time you see the patient so they see your name. And then the other two things that I did when I switched practice settings was I sent out a bunch of letters to the community for me in rhinology. I sent it out to the dentists, to the naturopaths in the area, and then developed a website presence. And that takes money. And you may not want to do that right away, but developing a website and whether or not you want to do YouTube or something like that, it certainly pays itself off. My monthly fee for the website management is easily paid for after a couple consults and endoscopies and things like that.
Yeah, I second the just like one-on-one communication. I have a lot of referring physicians that I share cell phones like numbers with. And honestly, when you're in a big institution, I can very commonly miss referrals. And so it's my one way to know how I can get people in. And it also helps me go and ask them for help too. And I think that's very key.
So this question about fellowship decisions and how to go about making the fellowship decisions, I'm going to ask our panelists to respond in the chat. And we're going to move on to our next slide. And we've got two slides, I think, that are the topic of specifically private practice, because we had a lot of questions, obviously, submitted ahead of time on these topics. There was one in the Q&A that I wanted to tie in first, and it was saying that there hasn't been a lot of discussion about how to get more of our new grads interested in pursuing careers in areas that are less populated, the less suburban, more rural environments. And so before we jump into the questions that are on the slide here, does anyone want to tackle that discussion a little bit?
Do you mind if I comment on that one? Dr. Powell, I'm not actually scheduled on your panel. Can you hear me now?
I can hear you. Please, Dr. Nanani.
This is, for those of you who don't know, I started in academics after I did a fellowship with Gene Tardy in facial plastics, only because that was the weakest part of the program at Penn. And then practiced in Houston, then ran Riley Children's in Indianapolis for the pediatric service while I was doing facial plastics and free flaps as well. And went to Knoxville in private practice. And I will tell you, I was most worried about whether I'd see interesting cases. I saw more interesting cases and because I had 2 satellite offices. It was before they got to anyone. And so I was doing a greater complexity and volume. Of course, that's been 35 years ago, but it's still, if you're willing to go, the reason I spoke up here is if you're willing to go to a smaller community, you can put whatever practice together you wanted to do. And from my perspective, why I love the specialty so much, I've done upper level specialty work in the subspecialties over 40 years in all but intracranial work and neurotology. So I think that don't worry about that. Some of the benefits of a smaller area is, one, you become very, very immediately integrated into the community, and you're very well respected. And the cases, if you get them before they go to the centers that normally would be referred there, you can still do them. And there's many areas like that still in the country. And that's some of these other questions. This is one where you could be in a 1 or 2 person practice, financially do well and not kill yourself if you don't have to be in the big cities. So it all depends on what your private, your non-practicing life wants to be. If you want to live in New York City, your practice is not going to be nearly as good as if you go to some of the rural areas as far as quality of cases, because you're splitting them with so many specialists where you wouldn't be. So if you're willing to live somewhere that's not, a top 50 population city, the opportunity is still there. I talk to many people like that.
Thank you, Dr. Nanani. So entering private practice, you could tackle any of these. So we'll go with entering private practice from fellowship. I think we've touched on that one. Did anyone have anything to add on whether it's feasible or recommended? I don't necessarily think that anyone made a specific recommendation to enter private practice out of fellowship, but I think any reason to enter private practice is a good one.
We actually, I would say that probably 50% of our fellowship trainees who've gone through our head neck program have either gone out and joined another hospital-based group or ENT group, or started their own head neck program, potentially in a hybrid model with a private practice and a hospital employed model, so that they're getting some of their compensation through that hospital. Don't forget, like, otolaryngologists are very valuable to hospitals and hospital systems, and so they know that, and it's important for us to know that we know that they know that. I do think that it's very feasible from a head neck standpoint, and I would say that head neck is the one that people are probably most questioning whether you can go out and just do private practice from that standpoint. So I think all the rest of them are pretty easily attainable through immediately after fellowship.
So with the hybrid practice model that was just touched on there, this hospital compensation-based model, can anyone elaborate more on these different types of models? That was just one. Are you familiar with any others to present to the group here?
I wish I had more experience with the hybrid model. And I'll say that after talking with Pablo Stolovitsky, he's given several nice talks about this, meaning he's in private practice, but when he does work at the hospital, he has an independent carve out so that he gets paid on a work RVU basis. The reason that's nice is you really don't have to worry about insurance. And what type of insurance, if it's a Medicaid type or Medicare or private, especially when you're on call. And we shouldn't anyway, but it's just nice to know that you're going to get compensated when you go in to take care of a patient, as opposed to if they don't have health insurance, then you're really not going to get compensated for it. So I think that hybrid model is something to work towards. It's just I wish I knew how to do it. It takes effort and probably a lot of legal know-how.
I heard someone else, but I don't know whose mic was unmuted. So please feel free.
Nope, that's exactly it. I know that if you join a private practice and you have a collections-based model with that private practice, a lot of times the hospital will, kind of compensate on the side for just having the head and neck services, because the hospital knows that you're going to bring your big cases to them. You're going to be on call. And you're going to be valuable to that situation. So it behooves the hospital to employ you and compensate you as well. And it takes some of the heat off of whatever your fellowship training is, or not within the private practice, so that you're not completely collections based.
So for this next question, I'm going to actually combine 3 of the questions on this slide and the next slide. So there was a question about private practice sustainability with the current regulatory environment, and reimbursements being reduced every year with, some of these legislative changes with CMS. But then there was also another set of questions on how to decide if a practice is, in fact, if it's a good practice to join. Like, are there certain metrics you should be looking at? Should they be opening up their books? Is there something specific as a person who's interested in joining a practice that you need to make sure that before you sign a contract? And then as far as practices that are or practitioners that are considering selling and or they're considering retirement, that question also came up. And so I think that kind of rolls into this whole sustainability piece. So someone gets to dive in on that big one.
I'm just going to make, this is definitely kind of not in my world, but I am just going to make a comment on the first one where you're talking about reimbursement. And I think what people need to also know, though, is that that's not just a private practice issue. Reimbursement essentially affects all of us as physicians. And unfortunately, it is a reality. So because I get paid by RVU, now every year, the dollar per RVU I get paid is dropping. And so at some point, I think it's going to become a huge issue for physicians across the US. I mean, if it already is, truthfully, but that's actually something that we're not immune to in academics. We have the same issue.
Yeah, I think, Krishna, maybe there's a difference in maybe your help with the regulatory side. Potentially more of that burden from the regulatory side falls, and we feel it more personally in a private practice. And maybe the larger your private practice, the less you feel that as we approach more of these academic looking private practices. So I think you maybe get some help from the regulatory side on an academic or a large private practice, but totally agree. I think the reimbursement reductions are felt all the way down the chain, and there's no large multi-specialty group or hospital that's just going to float the money for you and keep your reimbursement, your personal reimbursements high, your personal compensation high, when their own collections and reimbursements are decreasing. So that's going to trickle down in every model. But maybe the regulatory side of that question may be a little different from a small private practice to a large private practice to a large conglomerate university system.
So Dr. Burkhalter, then how would you counsel an individual, whether they're new grad or not, if they're just transitioning from an employed model or an academic model into private practice? What would you tell them to look for to say that this practice is going to be viable in 5 years or 10 years?
I think it's a great question. I think part of it, is the thing that's hard to put your finger on, which is the fit and the conglomerate of the partners together. And that's really hard, I think, as an applicant, because the fractions among people are probably what fracture practices most. And so that's really hard. But then I think watching how that practice uses technology and uses size and uses contract negotiations to leverage the abilities that they have to survive, and say how flexible and how nimble are these people, and how much can they move and swerve in a changing environment to address some of the challenges. And I think to see a practice who's able to be nimble and to change and address challenges using technology often, I think is one that's most likely to survive in a rapidly changing environment.
I would also toss in there that how well the practice is utilizing ancillary services and diversification of revenue is another indicator of how well they're going to be able to navigate or to overcome the compensation challenges that we face or reimbursement challenges that we face, because that reimbursement is usually only affecting a certain area. And so if you've diversified your income stream enough, then you're able to overcome some of that by increasing the amount of throughput in another area. For example, the over-the-counter hearing aids is going to impact hearing aid sale revenue. So is the allergy practice, plussing up its throughput in order to balance those things out. So how is a practice buy-in priced? That's our next question.
I think it's random. There's so many different models out there. I wish there was a model that everyone followed. When I was looking at other practices to join after academics, there was as many models as there were practices that I spoke with. So, they're going to value the company. You can ask or pay to look at the books and value the company. Do they own their own real estate? Do they own their own equipment? Are they renting the equipment? All that goes into the buy-in. You need to look at what the expected revenue is for you and for the years to come. So most practices will open up their books and show you, maybe not the first interview, but at the second interview, they'll show you what the partners are making, what the take home is. But then there's also the buyout, and some practices have buyouts. Some have buy-in and buyouts. And the buyout is when a partner leaves, they can get compensation. And our group doesn't have that. That always has concerned me a little bit with some groups. Like, what if all of a sudden 2 or 3 partners decide to leave at the same time, and now you're having to pay a bunch of money at the end, as opposed to paying money up front? You know what you're going to have to pay, and there's not going to be any surprises down the road. So that's a key thing. Make sure to look about the buyout. Not that it's necessarily bad, but you just have to be wary about it.
If I can jump in, one of the things that Greg just brought up was the transparency. And I think, Angela, you brought it up before. So one of the red flags about a group may be is if they're reluctant to show you their books, if they're reluctant to show you, what do they own? What are the partners making? As Greg said, it may not be the first interview, but if you're feeling like there's something hidden there, then you can be sure that whatever those secrets are, don't bode well for the future gelling of the group. Because if they're hiding secrets from you and they're hiding secrets from each other, that may not be a group of individuals you want to get involved in. So a lot of it is gut feeling on that.
So I was going to say, so then you've got buying into a practice if you're joining others that are well established, but what about the startup costs if you're doing it solo? Dr. Saib, do I need to put you on the spot?
You want me to talk about that? Yeah, those numbers can get pretty scary if you're starting fresh out, buying your own real estate, buying all your SMR carts, buying all your scopes. Those numbers get really, really big and huge and scary. And it's good to have a business-minded person, partner, advisor who is telling you this is the cost of doing business. So when the 3 of us left the hospital and we were opening our practice, we had all these huge expenses because we wanted really nice, distal chip cameras. Like, we wanted all the nice stuff, and it's wonderful. But it was quite an investment straight out of the gate. So obviously we got a line of credit from the bank so that we could buy all of that stuff. So we're paying on all that stuff now. But those are big, scary numbers in the beginning.
And I can speak to it since my practice just opened in October. And as a solo private practitioner, I think a lot of people looked at me sideways, maybe a little bit, because this is a climate where there's a lot of fear, I think, about starting out on your own, but it can be done. I think that having some realistic expectations for salary, you're not going to make the salary that you were making, even a few months before you start your practice. And I had some peer mentors that really gave me sort of the eye-opening, you're probably not going to collect a salary for the first year. And so that was where I had to be mindful and recognize that I may be living off of my savings for the first year, or have to do a line of credit or have to do something so that I can supplement my income and support myself until my practice is financially sustainable on its own. So with that, I think we've talked about tackling competition from nearby large healthcare systems, and I know we've talked about the on-call obligation. So let's go ahead and look at the business of medicine topics, and then we'll also kind of gauge the interest in continuing beyond 9:15. We're scheduled to go through to 9:30, but that's Eastern time, but we will continue to monitor for participation to see if we're running long. So for the anyone on the panel, if you could kind of summarize or discuss the various reimbursement models and levels of compensation that are available. I think we've touched on that, but this particular question wanted to get a kind of an overview. Do you think we've already covered it sufficiently? Because we can move on to, because I know we've spoken about the RVU reimbursement model versus collections model. If you think of something else, feel free to just kind of write an additional response in the chat there, and we'll move on to the overhead and skyrocketing costs of private practice. So we talked about the startup costs, but what about once you're kind of well established? What are you guys seeing for the cost to do business?
So I guess I'll jump in. So like all businesses, personnel costs are on the rise as inflation went up. We're definitely seeing increased salary demands. The MAs, the nurses, desk staff, they're expecting increased salaries, especially coming out of COVID, which most of us went skeleton staff during COVID. There were a lot of people transitioning, the Great Resignation. So a lot of us were understaffed in there. Everybody was working harder. But now as we bring our staffing levels back up, you're going to start to notice that personnel line creeping up, benefits as well. Now you have a lot more concentration. People got to spend some time at home. So there's a lot more push also for the higher benefits. And then across inflation in general, everything costs more. Your scope cleaning supplies cost more, your gauze pads cost more, your copy paper costs more. And on the unfortunate side, the insurance company rates were pre-existing, and there is no such thing as asking for more because inflation went up. And we know from CMS, there's no such thing either. As we found out, medicine is the only industry where the costs rise and CMS gets to decrease the amount. We're actually the only quasi-government contractors who don't get cost of living increases. We get cost of living decreases. If anyone else has sort of had a different experience, I'd be interested to see.
I'll summarize with one statement that I had my best year in collections ever this year, yet I'm taking home more than I did in 2019. And we haven't done anything different, and it's just the margins are slimmer. It's just everything costs more. You can only work so hard, and that's why you see a lot of the changes in private practice going on throughout the country, for better or worse. But that's the unfortunate reality. Doesn't mean it's not a great model. It just means that the adaptations you're seeing are because to address that, you got to get leaner.
Yeah. But on the positive side of things, many practices have learned how to do it. There are economies of scale. Practices are sort of teaming up in purchasing groups. We're figuring out smarter ways to use our staff. Crises lead to, and because a lot of the private practices can be more nimble, we can really figure out where do we need staff? Do you really need that to be a full-time position? Can that be a part-time position? What things can be done from home? If it's being done from home and remote, is that a different kind of salary level? So you sort of rethink a lot of those things. And then you also rethink, how much copy paper do I really need on hand? Sort of the nitty gritty stuff where maybe before, when things were less costly, you'd hold a lot more supplies. As Mark had said, you're going to run leaner now, but you have the ability to do that, to be nimble in those ways, because we learned, unfortunately, in 2020, how to spin a practice down. We learned how to take it down to the bare bones. We learned how to build it back up, which I don't think, at least in an independent business, there has been that kind of opportunity to dissect your practice, figure out how it works, sort of slow everything down, take a look at it exploded, and then put all the pieces back together, look to see how they mesh, and see what pieces really weren't so necessary, what jobs you could have cut out. So again, higher costs, but a lot of room to figure out how to do it more efficiently.
And this is where I'll plug the private practice study group one last time before people start weighing off, is that's why this group, one of the many reasons this group has been so successful. And thanks to Jim and honestly Gene, who we didn't introduce, who is on the board of the Academy and was instrumental in getting this group started. That's why this group has so much interest, because we all love private practice. We love what we're doing. We love why we're doing it. But there are real legitimate pressures on business, and they're not unsolvable solutions. Everybody does something well, and everyone does something differently well. And if you're not in the private practice study group, they'll give you how to join later. But we're all sharing best practices, learning from each other, not colluding, of course, but sharing how to do what we need to do to. Yeah, that was for you, Jim. Keeping our practices viable so that we can continue serving the community. Now I'm going to shut up before I take the rest of the 20 minutes.
So I was going to do a plug. So you gave the plug for me, but I was going to do a plug specifically for the ENT Connect private practice study group, that everyone sign in and sign on and actively participate, because several of the questions that are falling into this business of medicine section, you'll see a very robust dialogue about these types of challenges within the blog, within the ENT Connect. And so calculating the first year salary and benefits, who's going to tackle that question from our panel?
Without using numbers, please. Thank you.
It's well defined for us. There's a number that all the new partners who have come in and started out have gotten, and it's been every time someone new has come in, they've always kind of had this upward trajectory in terms of RVUs and what they're collecting, and it's always worked out for us. We really haven't had anyone fall behind, and it's a stepwise approach. And I am also quite fortunate that the people who have been here much longer than I have in my practice made it kind of a socialistic situation where everyone has the same after 3 years. So it's kind of a ramp up every year to a higher salary as long as you're kind of hitting your RVUs year to year. And the benefits that, therefore, I will say that is one of the big things about an employed contract with a hospital. There is very little give when it comes to your other benefits. And that's one thing that I did not talk about earlier, but whether you're a hospitalist or a radiation oncologist or sometimes a medical on call, just whatever it is, your vacation, your CME, your whatever it is all the same. And a lot of that's really hard to negotiate down because hospitals hate making they hate making concessions to one group, and then the other group hears about it, and then they have to try and make concessions to that group too. So that is one downside to negotiating, but that's what our model has always looked like.
And I'll re-emphasize just by saying, don't focus on that first and even second year. Look at the long term. And coming out of residency fellowship, you're going to be broke and in debt, and you want to make a lot of money, but it's more beneficial to look past this. And the other thing is, a lot of groups, your expenses, you're kind of expected to cover your expenses, and almost in some groups pay back your expenses before you gain partnership. So the higher your salary, the harder and longer it's going to take until you get to that point, if that's how your practice is set up.
I just wanted to acknowledge Dr. Brown.
Thanks, Angela, and thanks for leading the discussion tonight. I wanted to comment on a couple of different issues, and I'm so thankful for my fellow Charlestonian, Christian Patel, for participating tonight. I think it added a lot to the conversation, and I hope you guys listened to a lot of what she said, because we aren't in a silo. The economic forces are affecting the whole specialty, and I think that's where the academy really has a strong play, as in representing the specialty in terms of advocacy and reimbursement, and in terms of helping to create groups like this where we can share best practices and create platforms for the exchange of information. And I've had the good fortune of reading about 300 pages of documents that Jim Donnini's forwarded me this week in preparation for this upcoming weekend's BOD meeting. And I think that most of those documents reflect on these common challenges that not only private practice or academic otolaryngologists face, but also the House of Medicine, and how we're going to react. And I think that it's important for us to collaborate in these forums and to share information. But I think it's also really important for us to gather in larger groups in terms of supporting your ENT PAC and your AMA PACs, and to support the voice of medicine, so that we can continue to offer quality and access for our patients. As we see Medicare reimbursement at the same rate it was in 1993, and as we see inflation's increased by 106%, it's going to create major delivery issues for this subsection of patients. And as Jim is documenting on multiple levels, this is just going to expand out to more and more commercial payers. And our big rally needs to be in terms of supporting advocacy to amplify our voice, so that we can continue to offer best practices for medical care. I appreciate everything that all the leaders of this group have done. This has been an excellent forum. And again, Krishna, thank you so much for stepping out on this stage.
Thank you,
Just
Dr.
one
Brown.
comment on this question, Angela. You shouldn't have this question. Your contract, you should know exactly how it's going to be calculated. It shouldn't be in it. You should know before you sign it what it's going to be, because it's different in every group. But the one thing I would tell people is, some of the things, just because that was the same contract the last one they signed did, if something's more important, like the work-life balance, than a guaranteed salary of a little more, feel free to ask them what you want, because you'll end up with about the same size package. It may be a little different than the previous individual got, but it doesn't mean it isn't saleable to the group. One other thing that I've heard, listened to the difference between employment or not, whether it's academic. My biggest hurt when I left private practice to go back into academics was I had no control over the personnel of who we were hired. I worked for University of Missouri, and we had no say, even at the department chairs level, who HR sent to us. And believe it or not, that it becomes a big deal when they don't feel like they're working for you or your patients. They're working for the university or the hospital system. So that's one other advantage of private practice. You at least can choose, for the most part, your staff. But don't be afraid to ask a future employer, because for the most part, you're in less supply than their demand. And particularly if you're willing to go to smaller areas, and most of the time you can get a package that will meet your needs. It may have the same value, but just different portions are valued differently. So don't discount your own worth, as someone else said. I forgot who it was earlier in the call, but it really, don't go in with your hand out. Go in like you know something, and if it may be helpful to. We've promoted a couple of groups. There's one that's out there, I'm not going to mention them, but they can help you on your first contract, because they negotiate contracts for people all over the country. And if you're unsure, it may be worth your time to use someone like that the first time.
And so that was a perfect segue into shifting your compensation package for better work-life balance. And this example of a 4-day work week was just one that was provided from the individual that submitted the question. But what ways have our panelists made changes or requested negotiation of their contracts in order to provide for better work-life balance?
I'm just going to make one comment about academics, just listening to everyone talk, because similar, the one plus I think for academics is that if I go on medical global health trips, and I go on 2 a year, and then ultimately I take 3 weeks out of the year, because I do also international teaching on another week, and it does impact my salary. So those are 3 weeks of lost productivity, but the difference is that I'm not that it's a choice that I get to make, and I just accept that I get a lower salary. I'm not hurting my partners by doing that. And I think that's like, it's almost like I get to be more individual in that sense. Whereas I don't know, and maybe you have a little bit more like your partners are expecting you to be there, be more present in private practice. I don't know, but that is one nice thing that I feel like I don't have that constant feeling. I really am choosing to do it for my own lifestyle. It's just at a lower salary.
That's great points. And it's all about choice, and everything has a repercussion. And if it's a little bit less salary, then it may be worth it. I try to officially work 4 days a week, but my 5th day a week is always doing ENT based work, whether or not that's running meetings, designing meetings, CME events, or doing consulting work or medical legal work, or doing some research. All those things are possible in private practice and academics. And it's the variety that I like, and it kind of spices things up. Going to our academic meetings, academy, COSM, those are all important things for our growth, but still it takes the kind of monotony out of it. And that, for me, improves work-life balance. And, like this Friday, I'm going to go skiing instead of working. So nothing wrong with 4-day work week, but there are ways that you can get compensated on that 5th day and find some enjoyment as well.
We are, believe it or not, close to the end of our slides. And so the potpourri is our next slide, which was just kind of extra questions. I haven't seen anything pop up in the Q&A, but feel free to let me know if something's in there that we haven't responded to. And I think we spoke about partnership tracks, but was there any other pearl that anyone wanted to share on the partnership tracks that you don't feel was articulated earlier?
I think one thing that maybe we didn't talk about, and one of the, I don't want to say a benefit into the private practice is the partnership tracks are very fluid. I mean, even though you start out And, you may be told that, it's going to be a longer track to partnership. Sometimes, things are going really well, and there can be shortcuts in that way. So one of the important things, to keep in mind is if you feel that, there's worth in what you're doing and you're providing more worth than was expected of you, then speak up. You may find that the people you're working for are very receptive. And I think this works in an academic model as well, where, academic ENTs shouldn't, hold themselves back and not say that I'm providing more worth. And the same opportunities are available in private practice to move your way up. And if you feel either compensation wise or partnership wise that you're providing worth beyond what's expected, you can always, reach out and see whether there's an opportunity to renegotiate. So a lot of this stuff is not written in stone.
So I think, Dr. Patel, you were talking about international ENT opportunities. I don't think that the flavor of this question specifically meant mission work. I think they were speaking more to going overseas and doing fellowship training or participating in some type of, academic or research related endeavor where you have some combined international program with an academic institution in the US and something like that. But I do think that mission work would lend itself to a component of this question. So what are your thoughts?
I mean, I think for me, it is one of the best parts of my life that it is very, it's every, like, I couldn't go during COVID, obviously, like most of us. And so, and it really was sad because it really enriches my life to do that. And just like Greg said, every time we do things sometimes outside of our just set day-to-day practice, it really does enrich just who we are and our experiences. And I ultimately think it makes me a better ENT. So I just would encourage people, regardless of what model you choose to go down the road, there is always opportunity to go on global health trips. There's so much ear disease across the world. I mean, I do facial plastics and club surgery, but there is so much need for ENT. So I really do hope that people take that into account and take the time to do that, and it will enrich their careers.
I'll echo that. So I do a fair amount with medical students here in Columbia, and until COVID had taken students on a trip every year. And as part of a campus ministry we do here, but we'll take sometimes usually 20 to 25 students with a number of local physicians. And the past few years we've done Peru every year, but it's a great opportunity. It's so much fun to combine international health and international medicine with medical student education and watch students come alive as they learn medicine side by side with a new culture and new language, and just watch their world kind of open up. And so it's been a really, really great part of my life that I've continued. I'm really anxious to get it back after COVID. It hasn't come back yet for reasons of the medical school and things like that. But it's been a really great thing. There's a ton of opportunities. Happy to help anybody get involved. There's a ton of opportunities to tap into. I would just really encourage you to do it if you have the opportunity.
So what about locums, everyone?
We all have a lot of extra time in our days, so we should probably get second jobs. Yeah.
I will say I've had a couple of people I've met early in their career, and a lot of them have used locums, and they seem to really like it because especially when you're starting your own practice, and just to your point, like you might have to break even or go into your savings. I've had quite a few people, especially in facial plastics, where you do stay in the red for almost 5 years sometimes, who use locums to go travel somewhere else and do trauma or whatever, and it worked really well for them.
So I can speak to locums as a former active duty military member as well. And so I found locums helpful. A lot of my colleagues found it helpful because military health system practice of otolaryngology obviously differs in many ways from civilian practice of otolaryngology, and to be able to go to sites across the country. Several of us are licensed in more than one state. We move around fairly frequently with our military assignments. And locums also allows for supplementing our income because military otolaryngologists make a lower salary than civilian equivalent. So for a lot of the reasons that people are interested in some type of salary supplementation or just to get a feel or a flavor for a certain area before deciding to make a move, locums is very helpful. And there's a shortage. There's a shortage of ENT providers, particularly in rural and underserved communities. And so if you have time and can provide that service in those communities, you will definitely have a lot of work and be greatly appreciated.
Yeah, I would agree with that, Angela. And I would say, in a place like Nebraska, there's a lot of rural community hospitals, and it's not uncommon to see locums come through the state. But it also potentially is an opportunity to identify an area or a place that you never would have thought that you would have practiced. And you might go somewhere for a locum and find out that you really love the community, and that can be a good way to identify a future job. So always keep that open as an opportunity.
So that question of retirement and selling your practice that I brought up earlier, we didn't get any takers. So if we have anyone willing to provide a little bit of insight into that discussion, either before we close out or in the chat, or we can obviously connect any of the individuals that are interested in this topic to private practice study group, to our leadership, and then they can get more information for you as well. So gender considerations, we're approaching the end of our discussion, and I thought this was actually an interesting question. Are there any gender considerations that should be brought to bear in choosing a subspecialty or pursuing a fellowship? Okay, are you going to make me put my former chair of women in otolaryngology hat on? I will, and I'm going to say no. I don't think that gender considerations should weigh into decision making for any particular fellowship options. I think that the capabilities to do whatever you have interest in doing and where you have aptitude should be how you make those decisions. And if you're feeling that you're being excluded from certain opportunities because of gender, then that's something that should be discussed within the academy at higher levels. And Dr. Brown?
I just think that, and many of you have heard me say this before, and I'll say this again, I think it's really important in private practices to take a look at who's on your composite pictures and to consider the barriers for recruiting women into your practices. I know I'm not very proud of the picture that hangs in my office, and there aren't enough women on that picture. And as we all struggle with recruitment, and most of our practices are based on having generalists in our practices, that in terms of being a private practice looking to expand into the future, we've got to look at what we're doing and make it more attractive for women. And I think we're going to have to be more open-minded, and we're going to have to consider different pathways and different terms of inclusion and involvement so that we can grow our groups and be more attractive of females who now are 50% of graduates, and we know 90% of which are tracking into academic positions where they identify with same gender role models and mentors. And I just think it's an opportunity and a needed challenge that we need to meet to bring more women into private practice.
I'm gonna toss back to Dr. Sipe to close out this session. And before I toss this back to her, again, I'd just like to thank the Private Practice Study Group for putting together such an informative group of panelists and to have such a lively discussion. We're thankful to all of the attendees who have taken time on a weekday evening to spend with us. And these gender issues, and I would also add DEI issues, which were not really part of our discussion today, but recruitment, retention, and workforce diversity should be top of mind regardless of the area or the type of an employed environment that you're seeking. And so more to come, and I think that those issues should continue to be discussed and highlighted. Thanks again.
Awesome. Thanks so much. I think there's one more slide. If anyone is on this call and wants to be part of the Private Practice Study Group, just email Dr. Dubin. It's mark.dubin@gmail.com, Mark with a C. Thank you, panelists. You guys were awesome. Everybody did a great job. And thanks for all the great questions. Mark or Dan, do either of you have anything left you want to say? Okay. All right.
We'd like to thank Melanie for putting this together and playing game show host. Thank you, Melanie.
You're welcome.
I'll make one final comment. As much as the PPSG is done, there's two things that are going to be happening you're not aware of yet that are you're going to be shooting farther up the ladder very quickly. So it is a great thing for those who are on this call that are not members of it. Please consider joining, because there's some things in the works just that have happened this week that I think you're all going to be quite pleased with, which will further entrench this as a vital, one of the most vital pieces of our organization. So
it's a good teaser.
And one of them is getting more exposure. That we're about to come to a deal that helps get more exposure for residents to get into the private practices during their residency. So I know that's one thing that will help Gene and practices like that to let all the residents, whatever their status is demographically, to see both sides of the coin. And then, and I think that will help with recruitment. So.
Awesome.
I will tell you that you can be thankful Dr. Dubin is doing such a great job. I don't know if he ever sleeps, but every time I call or whatever, I get an email or a text back within 15 minutes. I mean, I hope he's not leaving surgery to do some of these answers, but
there's people, you're on there with my kids that go through breakthrough, do not disturb, Jim. You
okay,
kids,
well,
so.
well, that
I'm
allows quick decisions and opportunities to be taken care of. So thanks for the whole leadership group from our organization.
I'm convinced Dubin's got about 7 APPs working for him.
Well, they all must have his voice because it sounds like him when I'm talking to him.
On that note, thank you, everyone. Good night. Thank you, Jim. Thank you, Gene. Thank you, all the panelists. Dave Melton and FM also are on the executive committee. They didn't show their faces. Thank you for their help and everything as well. Good night, all. More fun from the PPSG to come.
Thank you.